FNAC. Very important topic even when it comes to surgery. So listen to me carefully. When I say FNAC, fine needle aspiration cytology, like I said, FNAC. So the first question coming to your mind will be, how fine is the needle that we are using? Students are always fond of knowing the gauge and the size of the needle. So anywhere between a 25-26 gauge needle is used, but you will always come back to me saying that I read 23 gauge in some book, I read 27 in some other book. What will I mark? No, you don't have one needle for every organ, right? If you have to go into a big swelling like a lipoma, fatty, lipoma is not at all life-threatening. You can go with a very thick needle. We can even go with a 21 gauge needle. But if you have to go in something like a thyroid is very sensitive. It has trachea and vessels around it. You'll go with a very thin needle like a 26, 27 gauge needle. So you don't have one needle for everywhere. You look at the patient, you analyze the situation, and you pick up the needle. So needle is very fine. After that, so this is a needle as you all can very nicely visualize over here. Apart from the needle, we have used something called aspiration. How is aspiration? I've put a syringe. I can see that this is a syringe that has been put alongside it, and that is why this syringe is going to create pressure. This is going to be aspiration. Like you take a blood sample, na? Same way, you pull the syringe. Okay, but I want my hands to be very stable. See, imagine if the needle and the syringe are going in thyroid, what if I'm a first year resident, first day of duty, and my hands are shaking like this? The needle can go anywhere. I don't want that. I want a very good grip of this entire apparatus. So what is this known as? If you come ever visit me in my path lab, we will always call it, oh, give me the gun. Okay, this is known as a gun because it looks like a gun. We hold it like this with our fingers. It actually looks like a gun only. But obviously, it is, what is it known as? It has some other name, proper scientific name. It is a Franzen's FNAC handle. This is known as a Franzen FNAC handle. So F for F, Franzen is going to be the handle that we use for FNAC, or in simple words, the gun. So this is the entire apparatus. I have a needle which can be of any size. I have a syringe for pulling out the material, aspiration, and I have a handle to keep this entire apparatus intact, the Franzen FNAC handle. Now let's start with the process. Let's go on to doing a patient's FNAC. Have a look at this, guys. This is a thyroid FNAC being done, but I realized if I zoom in, can you see the thyroid has a very tiny little lesion? Means it's hardly 1 centimeter. If it was 1 centimeter, then it must have not even been visible. When I can't see a swelling, how will I put my needle into it? Think logically. Something that you see, you can put a needle into, but something you can't see, where do you put the needle? Which part? So what will you have to take the help of? I will have to call the radiologist. This is a real-time rad path correlation that occurs in the hospital. So we will have to do an ultrasound guided FNAC. Means the radiologist is going to put the ultrasound probe over here, and on radiology I will see, yes, this is that tiny 1 centimeter lesion. So as you're seeing it live on the screen, now you're going to put your needle inside it. From here, you are going to do the FNAC. So have you hit the exact target? If you would have just putting blind needles like this, you would have never hit the target. But with ultrasound, you have directly hit the target. So how do you decide that where will you do a blind FNAC and where will you do an ultrasound guided FNAC? That is obvious. I don't have to give you any guidelines. If I say there's a big swelling on the forearm which is 5 centimeters, anyone can see it with their naked eyes. You don't need ultrasound for it. You will directly put the needle in it. You will do an FNAC. So anything that is a visible swelling or a visible lump, you are going to do FNAC. On the other hand, if I say there's a tiny lesion only seen on ultrasound, then you will have to do an ultrasound guided FNAC. Now comes the next twist in the story. And that is, many students have asked me so many times, is this a spelling mistake? Instead of FNAC, you've written FNNAC. No, this is a technique. So for that, you will have to first tell me the full form of FNAC. So it was fine needle aspiration cytology, right? Now, instead of that aspiration, I don't put an aspiration. Means non-aspiration cytology. So fine needle, non-aspiration. Non-aspiration means, do you see the syringe? See, the fine needle is there, the needle is in the same place. But basically, why am I saying no aspiration? Because there is no syringe that is going to be present. I'm not pulling out anything. The needle itself is only enough to take the sample. You put the needle, 1, 2, you put the needle and you're done. So repeating once again, please remember that you are not putting any syringe. So you're not aspirating. That is FNNAC. Okay, whether you did FNAC means you did it with the needle, with the syringe, with the handle, or you did it without the syringe, FNNAC, either you did it with the radiologist or without the radiologist, whatever may be your methodology, your FNAC is done. Now you are standing there with that gun and that syringe. What should I do next? Sample aa gaya, sample is there. What should I do next? Now you're going to put all that sample onto the slide. Now all that sample is going to be you will put it out into a slide. What can you do with that slide? Either you can just keep that slide on the table, means you will air dry it. You don't add any chemicals, nothing. You put it on the table, you will air dry it. Why will you air dry it? Which kind of stains do you want to put after that? I want to put the Romanovsky stain. I think by now everyone knows, and if not, I'll repeat. Romanovsky is usually belonging to the family of the Giemsa stain or the Leishman stain. These are the kind of stains which belong to the Romanovsky members. So you just dry it, you keep it on the table, you let it dry, and then you put your stains. On the other hand, if you decide to dip it into what? If you decide to dip it into 95% ethanol, why have you decided to put it in this fixative? Does this remind you of something? 95% ethanol is the fixative of what? It is the fixative of a pap stain. Suddenly you will feel, what is this? Pap stain, I was supposed to read in gynae chapters, pap smear. Pap stain is a stain that I can put on any slide on this planet. Many students believe that pap stain can only be put on a pap smear. Why? It's a stain. It's the same pink, blue, green colors. I can put it on any sample. Can I put it on an FNAC sample? Yes. In fact, this gives you better nuclear details. This gives you better nuclear details. So repeating once again, guys, you got a slide, you got all your material. If you let it out in the open, let it dry, you will be able to put Romanovsky stain. If you dip it in a solution, which is the fixative, very famous previous year question, 95% ethanol, means you're ready for a pap stain. Okay. Now I want to ask you a question. Is there any situation in which you would not want to do an FNAC? FNAC is contraindicated. Number one, if the patient is having any bleeding difficulties or bleeding defects. Imagine the patient has a platelet disorder, hemophilia, clotting factor disorder. You put needle and after that the patient is not going to stop bleeding only. So if there are any bleeding defects, don't do FNACs. Second, very, very important, which I think everyone knows, FNAC is not done if the radiologist has suspected hydatid cyst. Why? Because if you put a needle in hydatid cyst, there is a risk of anaphylaxis. There is a risk that the patient might die of anaphylaxis. So remember, if you are going to get this question, remember, never put a needle in hydatid cyst. Where else are you never ever going to put a needle? Remember, FNAC is not done or advised in testicular cancers. If a patient is having a clinical suspicion of a testicular cancer, never ever do FNAC, because this is going to result in spread of cancer. If you put a needle into the testis, you might make way for spread. This can result in spread of cancer. So having said that, never do FNAC if someone has a bleeding problem. Never do FNAC if the radiologist is suspecting hydatid. Never do FNAC if the clinician is suspecting a testicular cancer. These will be big time blunders. Never ever do that. This is where contraindication means FNAC is a big no. You do it and it's on your degree that you're putting a stake at. So remember, you're not doing an FNAC. But in which situation is FNAC a pitfall? Means you can do FNAC, but it's not going to harm the patient. There's no harm to the patient, but you're not going to get much of a benefit out of it. Where does FNAC fail? Because it is definitely failing somewhere. That is why it's not my gold standard, right? Where is it going to fail? So please remember, it cannot differentiate between a particular thyroid tumor. It cannot differentiate between the benign and malignant of thyroid. Means, what is the benign of thyroid? Follicular adenoma thyroid. It cannot differentiate between follicular adenoma thyroid and follicular carcinoma thyroid. You do FNAC, it's not going to harm the patient. No, there's no life-threatening situation for the patient, but it's a drawback, it's a pitfall. Why? Why is that so? You will want to ask me, because you can diagnose every other thyroid cancer. Only this thyroid cancer is a problem. You can diagnose papillary, medullary, all others, but this follicular thyroid cancer is a problem, because for the diagnosis of thyroid cancer follicular type, you have to look at two criteria. The capsule of the thyroid has to be invaded. The blood vessel of the thyroid has to be invaded. Now just think logically, you are using a thin 27 gauge needle and going into the thyroid. With that much of needle, can you take out the entire capsule of the thyroid? Can you visualize the entire capsule? You can't. Can you take out all the blood vessels of the thyroid with that tiny little needle? You can't. When you are not looking at a capsule only, and when you're not looking at a blood vessel only, how can you give the diagnosis? So the pathologist plays very smart. Pathologist never commits whether it is adenoma or carcinoma. Pathologist gives a diagnosis of follicular neoplasm. Pathologist gives a diagnosis of follicular neoplasm, which means it could be benign, that is adenoma, or it could be malignant, and that is carcinoma. So this means this is not the gold standard. So now, for example, patient came with a thyroid swelling, you put a needle, you said, I cannot differentiate whether it is adenoma, carcinoma, I am giving the diagnosis, a broad category, follicular neoplasm. What is the gold standard going to be? Now comes the story that till now, never did I call the tumor marker as the gold standard, nor FNAC as the gold standard, because the gold standard shall always be biopsy. The gold standard shall always be biopsy. So remember, biopsy, as all of you know, either you can do a true cut biopsy like you do in cases of breast cancer, prostate cancer, or you can do an excision biopsy. What is the difference between them? True cut biopsy means you are taking a core of the tissue. So for example, if this is the breast and here you have a cancer, here you have a cancerous growth over here, you say, I just want to take out 1 centimeter core out of it. I just want to take out 1 centimeter core out of it. That is a true cut or a core biopsy. On the other hand, you say that I want to take out the entire tumor, excise the entire tumor. So if the entire tumor is excised or the entire lump is excised, that is what you call as excision biopsy. You've understood the difference? If you take out a little bit of tissue, 1-2 centimeters, core. But if you've taken out the entire thing with the capsule, this means you're dealing with the excision biopsy. Whatever may be the biopsy, I think everyone knows this much of information by now, that whatever biopsy you will take, how will you send it to the path lab? A very, very important question that you guys have. So please remember that no matter how you take the biopsy, either you are sending it for a light microscopy or you're sending it for an electron microscopy. So for light microscopy, the fixative that they ask you, which is very, very famous, is 10% neutral buffered formalin. It is 10% neutral buffered formalin, or in other words, if they write NBF, that means the same. Neutral buffered formalin, but 10% you have to remember. Whereas if you're sending the biopsy, which biopsy do you send for electron microscopy, guys? Kidney. Kidney chapter has a lot of those black and white electron microscopic pictures. Then which solution will you send it in? You will send it in 2 to 2.5% glutaraldehyde. 2 to 2.5% glutaraldehyde. So repeating once again, if you are considering a light microscopy, give it in formalin. If you're wanting to sending for electron microscopy, give it in glutaraldehyde. All said and done, biopsy will always be the gold standard. If the diagnosis is made, very, very good. If the diagnosis is not made, now comes the famous question, how will you do the staining protocol? Okay, so your sample has come. What colors do we put in pathology? Let's, for example, consider light microscope. Let's not consider electron microscope for the time being. Can you tell me that if you sent a sample for light microscope, you put 2 colors? We always put there's something called pink and then there's something known as blue, right? Pathology is the world of pink and blue. You must have heard this line from me a million times, right? So what is that pink and blue? Remember, the pink color stain that you use, the pink color stain is going to be eosin, and the blue color stain that you use is going to be hematoxylin. It is hematoxylin. And the question that you get, the blue color is the hematoxylin. They ask you, what is the history of hematoxylin? So please remember, hematoxylin has actually come in very olden days. You will see that they used to, they realized that if they had to change dyeing of clothes, you've seen how they change colors of clothes. So from very olden times, what they used to do, there was a tree known as heartwood of logwood tree. Heartwood of logwood tree. From that tree, hematoxylin used to come out. There was a dye that used to come out with which they used to put it on clothes and they used to tie and dye clothes. Then they gradually realized that the same dye can be used in pathology. So that has been a previous year question, that what is coming from the heartwood of logwood tree, and that tree has that every botanical name you have to know. Now remember, there is something known as Hematoxylon campesianum. Hematoxylon campesianum. So that word has hematoxylon, so I am saved, right? The heartwood of logwood tree gave us that hematoxylin. So this is the pink and blue that we keep doing in pathology. So if the diagnosis is made on pink